Hi, everyone. How are you? Thank you for being on the call. We will start promptly. Hello. We will start promptly at 1:30. I'm going to go ahead and share my screen. So let me know if you cannot see it. Can anyone not see that?
Looks good, Melissa.
Okay. Yay. Thank you. All right. Make yourself comfortable. We'll start at 1:30. So get a beverage, whatever you need. And I'm going to take myself off camera and mute, and I'll talk to all of you soon. Hi, Michael.
Good afternoon.
Okay. Well, we are right at 1:30, so we shall go ahead and start the call. Thank you for being here, everybody. I have just a couple housekeeping things to go through before we officially start. My name is Melissa Temke. I'm the Behavioral Health Communications Manager for the Healthcare Authority. This is the monthly Behavioral Health Service Provider listening session for behavioral health providers. We have a great agenda today. Michael Langer is going to take us through the section update. And then Roxanne Waldron is going to take us through Medicaid and problem gambling. We have Teresa Claycamp and Yvonne Keller that are going to take us through the SPA amendments. And there will be time for questions. So you can go ahead and raise your hand. You can type your questions in the chat. It is up to you. You can also shout out your question. Try not to interrupt each other. And if you're not speaking, then go ahead and mute yourself. With that, I'm going to take it away to Michael Langer. Thanks for being here, Michael.
Thank you, Melissa. I'm trying to get my camera to turn on here.
Oh, no.
There we go.
Uh-oh.
I got it.
Okay, there you are. I see you.
Very good. So first of all, I'd just like to welcome everybody to our February all provider call. It has been a busy 2024 thus far. I think many of you are probably following our legislative session and recognize that while there are many behavioral health bills, there's also quite a significant amount of attention and recognition in the budget. So the House and Senate budgets both came out last week, and in many ways they match up to the governor's budget that came out in December. And in other ways, they've added some new ideas. So I think if you look at the House budget, that probably has the highest number of individual provisos, and we're up to about 148. What that means and provisos mean is just specific direction on specific projects. So there is a lot there. That's just a long way of saying there's a lot in the budget. We are answering a lot of questions right now, both on bill amendments as well as budget provisos. And we should see the conferencing of the two budgets in the coming days. And then we're about, 9-10 days or so from sine die or projected sine die. So things are wrapping up pretty quickly in this short session. And behavioral health has certainly been a priority of, again, the governor, the House, and Senate leadership. So we're quite appreciative of that. Also, I will say that we're continuing our search for a DBHR director, and so that's progressing well, and we'll keep you apprised. I would assume within the next, I don't know, I don't want to guess the number of weeks it will be, but this spring we should be able to let you know who our permanent DBHR director will be. So with that, I'm going to go ahead and move on because we have a lot to share here with you today. We have on the substance abuse prevention and mental health promotion section, the results of the Healthy Youth Survey for 2023 are scheduled to be shared publicly on the 13th of March. And again, for those of you that may not know, this is grades 6, 8, 10, and 12 across the state in our public school system. And for the smaller districts, they get some additional grades in there, but it's primarily 6, 8, 10, and 12. We also have data books that were the 24 data books produced for Community Prevention Wellness Initiative communities will be sent to the coordinators by June of 24. This will be include the 23 Healthy Youth Survey data, as well as all the archival data that typically comes in. We also have the 23 adult young adult health survey. I'll get it out one way or the other. And the annual frequency report will be available in March too. So a lot of the data, both from young people and from young adults, will be out this spring. And then presentations on the young adult survey will come out in March and May. The 23 CPWI community survey has been completed and results sent to the CPW coordinators in February of 24. So I don't know if you have them yet. If not, it looks like you'll get them in the next couple of days. We've got leap year, so we have an extra day to get it to you, I guess. But a lot of data coming out on this slide. So really thank the team and thank you in the community for participating in the school survey, young adult survey, the community, CPW community survey. Next slide. Okay, from our adult substance use and treatment section, we've got emerging approaches to treating fentanyl use disorder. And it looks like there's a series facilitated by Mark Duncan and Maureen Oskadal that will be talking about these trends. You see the dates are labeled in here. And there's a registration. It started, it looked like the first week in February. And so if you missed the first one, I'm assuming you can go ahead and jump on the rest of them and learn more about that. ADI resource use, substance use prevention, education, harm reduction, an overview of safety first. And you can see here there's a school curriculum created to educate young people about prevention and harm reduction with a YouTube video. So like a little, some of this prevention work maybe got into the treatment section here a little bit too. Next slide. All right, this is in the prenatal to 25 section within DBHR. And there's some listening sessions, exploring insights from the, I gotta get this right, Infant Early Childhood Mental Health Statewide Tour Report. There, that's what the acronym stands for. And you can learn about these discoveries from the HCA's 10 listening sessions. Also, the Saying Out Loud conference is happening. It's the organization of that comes through our P25, but it's for all of us. And it's May 19th and 20th in Yakima, the Convention Center, a 2-day this year. And it's a Saying Out Loud conference began in 2001 to provide space for education, networking, and sharing knowledge to improve care and support for our 2SL LGBTQIA+ individuals, families, and communities. And so this has definitely been a growing conference. Now we're up to 2 days and we're going to Central Washington. Finally, on April 30th and May 1st, there's a psychosis care virtual conference. And you can see a little bit of information about dedicated to cultivating community awareness, delivery resources, and facilitating on first episode psychosis. So 3 different opportunities there being shared by the prenatal section. Next slide. Okay, we have the, I think the adult substance use disorder treatment section. Again here, we have SAMHSA's webinar and report on examining the use of braided funding for SUD. And that is February 29th. More information, you can register here. There's also looks like there's an updated overdose prevention and response toolkit, and there's a link to that toolkit. So a couple more resources for you there. Next slide. Funding opportunities. So these are, looks like 3 different, or there's more than that, several different funding opportunities. We try to send these out through Gov Delivery. Gov Delivery is the mechanism you get notices about this meeting through. So you should be getting information about quite a few other things throughout the month as they become available. And here's some grants that are out here. There's like 1 or 2 from SAMHSA, and then a couple of them here from the Bureau of Justice Assistance as well within the Department of Justice. So we look at these when they come into us and sort of screen them. Is the state eligible or not? Is it large enough for us to go through and then be able to serve many communities? Many of them come through, and it's the size of the grant and the scope of it is much more aligned with community applications. So as soon as we get those, we try to get them out quickly so that you have ample time to apply for them. Next slide. Okay, it looks like this is the mental health adult and involuntary services section. And the fee-for-service program, a rate increase went into effect on the 1st of January. So if we didn't say that in January, we're letting you know that in February. And then also it says endorsement standard WAC writing. We've initiated rulemaking for the endorsement of mobile rapid response crisis teams and community-based crisis teams. Also, endorsement signifies teams are able to respond to a crisis quickly and be able to voluntarily transport a person to a crisis facility if necessary. So a little bit more on the WAC writing. I'm sure you'll see more pushed out in terms of comment time. Next slide. And this is our recovery support services section. And it looks like we're announcing acceptance into the Housing and Services Partnership Accelerator with federal partners of the HUD, HHS, and SAMHSA back in our federal government. And we'll join 7 other states and Washington, D.C. on a 12-month program to receive TA and peer-to-peer learning opportunities to strengthen partnerships across housing, disability, aging, and health sectors. So we're pretty proud of the work we do here in the state of Washington, and we do have good relationships across departments. But the federal government offers us these opportunities periodically to just come together in a more focused sense and actually create some plans or create some strategies together. So we try to take advantage of those if we can. There's also a 40-hour crisis awareness and communication and peer support training is required for certified peer counselors working in crisis settings, and registration is open and seats are available. So please reach out to Amanda Paula if you have any questions on that. The Washington Peer Network is an online resource for employed peer counselors. Employed peer counselors can register here and you can get yourself on that site. And then the Peer Pathways Conference is scheduled for August 21st and 22nd in Yakima. You'll see more and more of these conferences announced as the months go by, as we do quite a few in the summer and early fall. Next slide. All right, I think this is the point that I transition this back to Melissa, and she will introduce our speakers as we go through the hour. So, Melissa.
Fabulous. And I actually think so what is next is problem gambling. And I'm going to stop sharing my screen momentarily, and I'm going to put the links to the slides in the chat so that you will have access to those links for funding and things of that nature. And I'm going to hand it over to Roxanne, who's going to be sharing her screen and talk about problem gambling, and then we will go to the SPA update. Welcome, Roxanne.
Hi, thanks. I'm just getting my slides ready. Hold on just one sec. Okay, can you see that? Melissa, can you see that? Okay?
I sure can. I sure can. Yep, looks good.
Great. Okay. So I'm Roxanne Waldron, and my pronouns are she and her, and I'm the administrator of the State Problem Gambling Program within the Division of Behavioral Health and Recovery at the Healthcare Authority. And today my co-presenter will be Tana Russell, and she is the Deputy Director at the Evergreen Council on Problem Gambling. You'll hear from her in just a moment. So today we'll be sharing with you about new problem gambling services that are available, and then giving you specific information about how to become a certified gambling counselor, as well as how to refer people to services for problem gambling. So this is not only directed at individual providers, but also at behavioral health agencies. So before we get started, I'm going to hand this over to Tana for 2 polling questions. Tana?
Yeah, so if you could, at the top of your screen is a button that says chat. Get that ready because we'll have you put your answers in there. But first, as she said, yes, my name is Tana Russell. I am Deputy Director of the Evergreen Council on Problem Gambling, and I've been with this organization for over 4 years now. My background is as a counselor, SUDP, also specializing in tobacco treatment and gambling treatment. With previous experience in hospital settings, OTP settings, criminal justice settings with youth and adults. So to kick this off, you can put in the chat, and let me get it open for me as well. If you are A, B, C, or D, what is your experience with problem gambling? Personal, don't put any names, this is anonymous, but you know someone in your personal life, friend, family member, colleague, friend of a friend, whatever. Professional, meaning you know someone in your professional life. It's a client, it's your colleague's client, etc. If you're C, meaning both personal and professional, you've seen this issue come up, or D, none that you know of? So I'm looking at the chat and it looks like there's kind of a mixture of them. I'm seeing a whole lot of C's. Lots of letter C seems to be the most common, both A and B. Both A and B for some of you. Some just A, some just B, and some D, none that you know of. And I say it that way because, like many things, you maybe do know someone who's struggling with this, but it just hasn't come up. All right, let's ask the next polling question, which is, so now we know you're seeing it, most of you, at least a clear majority of you are seeing this issue come up, either professionally or personally, or a little of both. A few of you have not, most of you have. Now, what degree of training on problem gambling have you had? A is little to none. Excuse me. Maybe we're the first people you've heard talk about it, or it's been a long time, or you can't remember anything, or it was just totally insufficient if you had something before. Moderate, you've had a decent amount, but you don't consider yourself a specialist in this area. And C would be you are a specialist already, or you're maybe on your way towards it, had like the 30-hour intensive basic training on gambling counseling, or some sort of specialist in your field. So it looks like we've got a lot of A's and B's, one C here. Oh, Tyson. Hello, Tyson Lee. Lots of A's and B's, lots of A's and B's. Okay. And we've got one other certified gambling counselor in the audience. Excellent. So this is not uncommon. Every time I ask these two questions, whether I'm in a webinar or a live setting, that tends to be the trend, is a clear majority of the audience is seeing this issue, and also they're not getting trained on it, which is also my experience early on in the field, where I kind of stumbled into discovering that gambling could even be an addiction, and what to do about that. As a counselor early on, I had nobody talk to me about it. I was just released into the field without any training on it, right? So this is just something to kind of show that it's an area everybody's seeing and we need more training on it. So hopefully what we're able to cover for you today will get you pointed in the right direction for any more information you do want to dive into to better help those people that you are seeing struggle with this.
Great. Okay, I'm going to jump back in here. So I just want to share with you about how people can access problem gambling treatment in our state. People can go through private insurance. Some folks are covered by private insurance, or they may be able to pay out of pocket, so self-pay. There's also, maybe they have it through their managed care organization, or maybe tribal behavioral health. And actually, in fact, most tribal behavioral health programs serve both tribal and non-tribal community clients and families, and many of them do have problem gambling programs. And then for individuals who don't have coverage in one of those ways, or they can't completely cover their costs, since 2005, the state problem gambling program has contracted with provider agencies or sole providers to provide free problem gambling treatment. But we have a new exciting option, thanks to hard work of people at HCA. We now have an option for Medicaid coverage of problem gambling assessment and treatment through behavioral health agencies, and that includes tribal behavioral health agencies for both managed care organization and fee-for-service clients. So for behavioral health agencies, they must be a DOH certified as a problem gambling agency, and then the services must be given by a certified gambling counselor, level 1 or level 2, and Tana's going to tell us a little bit more about that in a moment. So Medicaid coverage, as I mentioned, just started. Problem gambling has been added to the SERI, the SUD, and fee-for-service billing guides. There are billable services under Medicaid that include assessment and individual, conjoint, family, and group sessions. Unfortunately, there's no case management or supervision directly under that. And unfortunately, also, sole providers can't bill yet. So if you are a sole provider who does bill Medicaid for SUD or mental health, you can't bill yet for problem gambling, but HCA is working on that piece of it. And then the state program will also continue to serve clients. So we're not changing at all, the program that I oversee. And for problem gambling contracted agency, of which we have 11 right now, agencies or sole providers, we're asking them to move their Medicaid eligible or Medicaid enrolled clients or Apple Health enrolled clients from off of our state program onto the Medicaid. So that will free up more money for our program to spend on people that are not eligible for Medicaid. We're asking them to do that by April 1st, so we're kind of in this transitional rollout. And then to access services, individuals can contact the Problem Gambling Helpline. We have the number here, we'll share it again, for referral for assessment. And clients can also self-refer. And on the last slides, we'll share the contact info for the state problem gambling program. On there, I have a list of contracted providers, and also for the Evergreen Council on Problem Gambling, where they have an online directory of certified gambling counselors. So this slide identifies gaps in our state certified problem gambling treatment services. So the categories are geographic regions. We have about 11 or more areas in the state where we've identified where we don't have any or have inadequate service availability within a 1-hour drive time. And some of these are actually areas that have commercial and or tribal gambling within them or nearby. They also were looking for clinicians who speak languages other than English, especially for populations known to be at an increased risk for problem gambling. So that includes people like clinicians who could speak Spanish, Chinese, Korean, Russian, Tagalog, Vietnamese, and others. And also we're looking for folks who are working within communities for populations known to be at a higher risk for problem gambling or gambling disorder that have no problem gambling services nearby or inadequate supply of them. So this includes communities with a higher percentage of Black, Indigenous, and other people of color, communities with low socioeconomic status, and based on the social determinants of health, they may also, lack access to healthcare, education, healthy environment, and food and work opportunities, and so forth. Finally, we're looking for clinicians with lived experience from those same communities. So often people feel more comfortable talking to someone who looks like them or has had a similar life experience. So this is why we're talking to you today. So here's the map showing some of the areas of the state that we are focusing on to increase access to state certified problem gambling treatment. I just want to emphasize, we want counselors all over. They do not have to be specific to these areas. But with the beginning of telehealth being really available now, many people choose to do telehealth, so you don't necessarily have to be in the same area. And I also want to note here that there are several tribal behavioral health clinics that have certified gambling counselors, and there are some that don't. So tribal clinics are more likely to have wraparound integrated services for problem gambling that are culturally appropriate for their communities. So several of these programs are located within the geographic regions on this slide. And the focus of the workforce development is on state certified problem gambling treatment services, not the services that tribes provide as sovereign nations. Tribes determine what services they wish to provide within their individual communities. They certainly can also have certified gambling counselors and be a certified gambling counseling agency with the Department of Health. So to fill these gaps in the state certified problem gambling treatment, the Healthcare Authority and the Evergreen Council on Problem Gambling have launched a new workforce initiative to increase the number of certified gambling counselors and problem gambling certified agencies in the state. So we're using a multi-prong approach. We are training additional problem gambling certified gambling counselors to fill those gaps in both region, language, and also lived experience. We're incentivizing existing behavioral health agencies to identify one or more clinicians to become certified. We are encouraging agencies that accept Medicaid to employ or contract with a new or current certified gambling counselor. We also have a way to help cover the cost of that training while the person is in training, and also that you can begin billing early on. And then another option is to contract with the state problem gambling program. And we now have additional funding over the last year, and the encounter rates have just been increased by 25 to 56%, depending on the service. So we're really excited to bring that up from 2005 rates, a little bit higher. So to encourage clinicians and behavioral health agencies to become state certified problem gambling treatment providers, the Evergreen Council that Tana works with with funding from HCA, is offering enhanced scholarships of up to 100% for training and supervision to become a certified gambling counselor within those specific areas that we're looking at. And then both agencies and individual clinicians are eligible for these enhanced scholarships if they will be filling an identified need as outlined above, or on a first come, first served basis. We have generous funding, but it is limited. And then additionally, the Evergreen Council is also offered to provide trainings for specific agencies and or within specific regions in which several agencies would like to become certified. So now Tana is going to share more about becoming a certified gambling counselor, as well as ways that all agencies and clinicians can identify and refer clients for problem gambling treatment services.
Thank you very much. Yes, so if you are interested in either becoming a certified gambling counselor, or you have a colleague or staff member who is interested, this is a very brief overview. In Washington State, there are 2 different credentials that are recognized. One is an international and one is a state level. The international is through the International Gambling Counselor Certification Board. So on this table, you see there summary of requirements on the left side, and then the Washington State level, which is on the right side. At level 1, they're very, very similar. Have to have a bachelor's degree or equivalent and have to already be a Washington State Department of Health licensed provider, whether that's an LMHC, LCSW, SUDP. There's like 15 of them, but you have to be a licensed counselor in the state of Washington first. The gambling counselor certification is an add-on to that. The training to become a gambling counselor doesn't teach you how to be a counselor. You should have already gone to school and be licensed and practiced in that. It just teaches you how to take that training and apply it to working with gambling disorder is the idea. So that is the 30-hour training, much easier than going through college for another 2 to 3 years. 100 practice hours, which do need to be supervised. It cannot be your normal mental health or SUD supervisor. It has to be a gambling supervisor, and they do not have to be on site. There's only about 10 or 11 in the state, so they do supervision from a distance. So for some people, they may have 2 supervisors, their on-site mental health or SUD supervisor, plus their gambling supervisor they contract with elsewhere. And then, of course, there's an application fee. Now, in Washington State, the certification committee did add a training requirement a few years ago that in order to get certified and every 2 years at renewal, there has to be 6 hours of cultural competency training. Doesn't have to be that exact thing in the title of the training, but around cultural competency is the theme. We're not making the 30 hours now 36, but it does cover that a little bit. And then they get the extra elsewhere sometime in that first 2 years towards getting certified. Now for level 2, this is where the international and the state level vary quite a bit. For the international, in order to get to level 2, it goes from 100 practice hours to 2,000 practice hours for level 1, whereas in Washington State, it goes from 100 practice hours for level 1 to 300 practice hours for level 2. So there's quite a bit difference there in terms of how long it takes someone to get to the higher level of supervision. It's just more training, more practice hours. They do not have to retake the exam. Anyway, there's a difference there. And on the next slide is some of the other requirements like letters of reference, statement from the supervisor saying, yes, they are licensed and they've been licensed for this many years, or they've worked for me this long, etc., that you have that practice hours as a mental health counselor or substance counselor, whatever it is. You've got some experience under your belt when you're applying. Signed forms like ethical standards, attestation, the directory authorization, the exam, or in Washington State, there is an equivalency alternative, a case conceptualization that gets reviewed by a panel of 3 certified gambling counselors. Exams are just not for everybody. So the certification committee spent about 3 years working on this exam alternative, great for individuals for whom, test anxiety is a huge barrier, or English is not their first language, and grammar and English is not even rated on the case conceptualization at all, for the purpose of reducing that as a barrier. Of course, the application fee and malpractice liability insurance, which most people who are practicing counselors, you should already have that in place already. Now, for referral to residential treatment, There is residential treatment for gambling disorder. There is withdrawal for gambling disorder, and there is residential treatment for gambling disorder as well. There is no residential treatment for it in the state of Washington at the moment. We hope to see that change in the future. So my organization, Evergreen Council, we have funding to help send clients out of state for residential treatment. The closest is in Salem, Oregon. We also contract with properties in Minnesota as well as Louisiana. Now that referral does have to come from someone who's certified. So someone's working on getting certified, they can just partner with a certified gambling counselor to make that referral. And next, so this is the question I get all the time. Okay, this sounds great, but in the year to 2 years it takes to get certified, what can we do to help the people we're already seeing? And what can we do to help people if we don't have anybody on staff who wants to get certified? What if we don't want to add gambling treatment to our menu? There's a lot that you can do without any kind of specialty Department of Health license, without any kind of specialty personal professional license. Screening, brief intervention, referral. Easy. Screen, do a brief intervention, refer this person to a certified gambling counselor that they can see. It is not double dipping. If they're seeing you for mental health and they want to see someone else for a gambling disorder, it's 2 different diagnoses, 2 different providers. Case management to help coordinate these, client education, community education, outreach, prevention, of course, integrating prevention into your programs, different media components or PSAs or campaigns. Problem Gambling Awareness Month, that's what PGAM stands for, is in March. Lots of properties will do community events, just raising awareness, making screens available, making education available, just generally increasing the conversation. And the easiest resource to use all of these is the helpline. One-stop shop, 24/7. They can get them connected with any certified gambling counselor in the state, and all but 2 do telehealth. And lastly is Gambling Disorder Screening Day, which is the 2nd Tuesday of every March. So it's March 12th this year. Some people will do Gambling Disorder Screening Day events. They'll set up a table at their local college, university, even in casino lobbies, if it's worked out with them. Okay, they get permission for that. And it's all just about making gambling screens and resource lists available to people. You don't have to make it into big conversations. It's not trying to get people into treatment. It's just raising awareness and trying to reduce barriers. All right, so where to find help service, that one-stop shop that's easy for people is 1-800-547-6133. That being said, a lot of people, helplines just aren't for them. They would rather go to their local behavioral health clinic or their tribe's behavioral health clinic or some facility that's even their pastor, someone that is trusted that they connect with to find help. So that's why we want to get this information out to everyone. So if they come via someone in their community that might be helping them to get access, they know where to go. You can also go online to our website. We have a support service locator where you can put in your zip code and pull up certified gambling counselors in your area. There's also GA and Gam-Anon. We don't have our map linked to theirs, but you can look up 12-step meetings in the area as well. And of course, tribal behavioral health programs, several of them do have certified gambling counselors or on staff, or they know where to refer to for that screening intervention referral piece.
Okay.
All right.
So I'm just going to skip past these 2 questions. They will be in the slide deck if you have questions, or you could contact me. We're close to the end, so I'm just going to say here's my contact information at Roxanne Waldron, and you can contact me with questions about funding for reimbursement for problem gambling treatment services, how to apply for a contract, current reimbursement rates, how to apply to become a DOH certified problem gambling treatment agency, and also if you have questions about the new Medicaid coverage for problem gambling treatment. I'm going to turn this over to Tana for the last slide.
Yeah, absolutely. There's my contact information. And now with our time, we can take questions. And I saw there was a question in the chat I was just about to chat to, but I'll just answer it verbally. Can anyone screen and can we bill for that? Yes, anyone can screen. It is not clinical. It is not medical. It can be done at a college counseling center. It can be done anywhere. People can pull up a screening tool online and screen themselves. It's very, very low barrier. Can it be billed? Depends. If it's done as part of a mental health or SED assessment, then it's basically just part of that session. It would not be billed separately, but you're still billing for the mental health or SED assessment. If it's done separately, if an agency has funding for outreach or funding for case management, something like that, then sure, it's part of that. A lot of places it takes 2 minutes, so it might just be a free consultation that they want to offer. Can we bill case management services? Often case management can be billed. So if it's part of your case management and you do case management for a lot of things and now you're going to start addressing gambling as part of your normal case management services, awesome. More holistic care, and you're just adding another option in for individuals. Let me scroll up and see if I've missed anything. How can we learn more about workforce development opportunities, incentives? Email Roxanne or I, and we can tell you more about that depending on specifically what your question is. Let's see.
There's a question about licensure. It looks like the question is, how long does it take for a BHA to become licensed, as we have been waiting for months now?
Sounds like a Department of Health license.
Yeah.
Is that right?
Okay. Yeah. Yes, I believe that. Juan, correct me if I'm wrong. Was that what you were referring to as are you trying to get licensed through the Department of Health?
Yes, we've submitted our application months ago, and we're still waiting. Excuse me, to get any information on approval for our license to begin providing those services. So, I was just wondering if we had any kind of a timeline. But we haven't heard back. We just heard back recently that they received it and our application was complete. But that was after months of having been waiting. So I just thought I'd ask to see if there was any amount of time that it takes, or who do we reach out to kind of get that going?
Yeah, that's a really good question. I don't know if we have anyone on here on this call from Department of Health. I do see Megan D. Gallagher's hand. Megan, did you have a response, or do you have any additional
Hi,
questions?
Melissa. It's Megan.
Hi.
It's D. Gallagher. Hi.
Sorry.
Oh, that's okay. No worries.
I have one of those names too.
I do have a contact. I'm not sure if I can share that out in this meeting or not, so I can check on that. If I could just get access to who asked the question and maybe their contact information, and then I can follow up.
Sure, I'll email you right now. Thank you.
Perfect. Yep.
Okay, well, I think we're done with our presentation. I know you have another one after this. Thank you so much.
Thank you. Thank you both. That was great. I am going to go ahead and re-share my screen again, and we will have Teresa. This is not the right button. Oops. We will share the other screen, and we will have Teresa Claycamp and Yvonne Keller tell us about the new spa update. Here we go. Here's the right one. There we go. Take it away.
Thank you, everyone. Thank you for having us today. So today, Teresa and I would like to come before you and talk to you about some Apple Health Medicaid state plan amendment updates that we're completing at this time. But first, I'd like to introduce myself. I'm Yvonne Keller. I use she, her pronouns, and I am the fee-for-service behavioral health program manager at HCA, and I ensure that Apple Health clients without a managed care plan have a behavioral health benefit. Teresa, would you like to introduce yourself?
Thanks, Yvonne. Teresa Claycamp. I'm the Behavioral Strategic Advisor for DBHR. Thank you.
Thank you. So next slide, please. So we are working on some state plan amendment changes, adding providers to 60 of the state plan. And you might ask yourself what the state plan gives us the state authority on what is Medicaid reimbursable and for services and provider types. So changes to this state plan are what we call a SPA state plan amendments. And the Center of Medicare and Medicaid Services, CMS, reviews each SPA to determine whether it meets federal requirements and policies. And then if they do not approve the SPA within 90 days, we at HCA consider it to be approved. The state plan is updated when CMS issues final approval of the SPA. Next slide, please. So we are adding 2 provider types to 6D of the state plan. We're adding associates and SUDPs. So the addition of associates will include licensed mental health counselor associates, licensed marriage and family therapist associates, licensed independent clinical social worker associates, and licensed advanced social worker associates. So when the SPA is approved, the Mental Health Billing Guide Part 1 will be amended and will be updated to include associates. And these providers will no longer be able to bill under their supervisor. So they'll know.
And Yvonne, before we go, yeah.
Okay.
Thank you. Before we get too much further, there was a slide that was missing. So I just want to make sure we tee it up for the audience.
Oh, sorry, I missed it. You did.
That's okay. So so the state plan is structured in a couple different ways. So many of you who are licensed behavioral health agencies are used to state plan amendments that amend a certain section of our state plan that really influences your work as a licensed BHA doing treatment. This state plan that we're talking about is for a different section of our state plan that is for non-BHA settings, so non-behavioral health agency settings. So that's going to be things like primary care and our rural health clinics and our FQHCs. So it's a kind of a different section of the state plan for Medicaid. And so I just want to make sure we're framing that. So this will be impacting the billing guides for those providers that kind of work more on the physical health side of the care continuum, right? So primary care, rural health centers, and FQHCs. So before we get too far in, I just want to make sure we frame that because many of you are used to Medicaid that impacts things like the SERI guide, like the Service and Counter Reporting Instructions guide. So this is actually a different area.
Yeah, so as Teresa says, thank you, Teresa, for that. I missed that slide was missing. So with that, we are adding associates to 60 of the state plan, and most of this work will be done in Mental Health Part 1. And like I said, this will no longer be allowable for associates to bill under their clinical supervisors. And these providers will work within their scope of practice and be the servicing clinician on the claims. And the anticipated date for the Mental Health Billing Guide to be updated is July 1, 2024. Next slide, please. Oh yeah, that's the
slide.
Go to the next slide. Yeah, they got flipped. Go to the next. So yeah. So next slide, please. We can go to the SUDP slide. There we go. Okay, so the addition will also include SUDPs in the state, in 60 of the state plan, and this will expand the settings that SUDPs can provide services within their scope of practice. And these include non-BH settings such as FQHCs, rural health clinic, primary care clinics, and other settings. And when we say other settings, we mean that these SUDPs could start a business on their own. So that this will expand their scope. So if the SPA is approved by CMS, the physician-related professional service billing guide will be will have these changes anticipated July 1, 2024. And the reason for that is FQHCs and rural health clinics, that's their parent guide. So that's where these changes will live. Next slide, please. So our intended outcomes is we strive at HCA to ensure that Medicaid enrollees have equitable access across the full continuum with a no wrong door approach. And we want to improve experiences by bolstering access to services and also looking at how integrated services is happening in primary care. HCA strives to help providers fully utilize available workforce and support recruitment and retention, especially in rural communities. Next slide, please. So we have our that we're working on. We've already we're halfway through the process. So right now we're presenting to our groups to let people know to let groups and individuals and agencies know what's going on. So we're in the February, March timeframe. March 29th, that's the end date for public comments, and my email will be at the end of this slideshow for you. So you can email me if you have public comments. And in April, we submit state plan changes to CMS for approval. And then by July 1, we hope that we have all of our changes ready and the state plan change and the billing guides updated. And next slide. So public notice and comment period is from February 6th to March 29th, 2024. There's links here where you can view HCA public notices. You can subscribe to HCA program updates through GovDelivery, and then my emails here for public comments. Next slide, please. So if you have any questions, we're opening for questions now.
I do see in the chat that somebody's asking about, does this mean associates will be able to provide fee for service in like a private practice capacity? So as like a sole proprietor, they would still need to be supervised, you know, to be an associate level, you are required to be supervised. However, the billing mechanism would be turned on for them so that they could be the person submitting the claim. So right now what's happening, again, this is more in the physical health side of the house, is these associates are billing under their supervisor because they're not called out in the state plan. By calling them out in the state plan, we're going to then be able to allow them to be the one who's submitting the claim or billing rather than their supervisor. So that's the big shift. There's another question, how long does the associate's license last? That's a Department of Health question. I would encourage you to get on their website. For each of the different professions, there's a frequently asked, on their website, they have frequently asked questions, and there's a lot of great information. So if you were interested in licensed mental health counselor, for example, and you wanted to learn more about the associate level licensure, there's a section on DOH's website that will speak to that. Am I missing any other questions in the chat? Will these individuals be required to submit behavioral health supplemental data the same as licensed BHA? Great question. At this point, we do not have the physical health providers submitting supplemental data. So things that are occurring on the physical health side of our continuum, rural health centers, primary care, FQHCs, what have you, that those providers at this point are not submitting supplemental data. We may need to do that in the future, but right now the community mental health and the community behavioral health side of the continuum, our BHAs particularly, are the ones that submit supplemental data. And again, that is a SAMHSA requirement. Trying to capture everything. Will associates being reimbursed at the same rate as full licensed professionals? I'll kick that over to you, Yvonne.
So yes, the reimbursement rate will be the same off the fee schedule. Those rates will stay the same. And you'll use the mental health part 1 fee schedule.
Great. Thank you both. Any other questions from the group? A lot of changes this year regarding behavioral health. So if you need to think about it a little bit, that's okay too. Yes, we will post the recording. If you don't see it, email me. It does take a couple of days. I would give it a week, honestly, for it to get turned into a YouTube link. And if you don't see it on our website, then email me and I'll send it to you. So the key one, I believe, was there. So I think the issue was that the order of them was just reversed a little bit. So, so the slide, I believe that should have been, let me share my screen really quick. Here we go. I think
the order just was slightly tweaked.
Yeah. So it's the attachment 3, right? That was the main one that you thought was missing that wasn't?
Yeah, it should have been slide 3.
Yeah. So that is actually in there. It looks like this. It says attachment 3, section 6D, other licensed practitioners.
Yeah, and I just think that was supposed to go in front of the other one. So just
okay.
If the order can be switched, that's cool. So slide 13 should be slide 12. Just flip those two and you'll be good.
There we go. Done and done. All right. Yep. I'll put that. Yep. Any other questions? Okay. Any questions about anything else? I mean, this spot update is a really big deal, but any questions about problem gambling? Any questions about what you heard earlier? Anything you'd like to learn more about? Any names you recognize on the call and you have a burning question for them? This call is your time, so feel free to ask away. Okay, I mean, that said, if you want 9 minutes of your day back, happy to do that too. Oh, okay. Any movement towards Medicare coverage when people do not have Medicaid but are low income? Great question. Michael, do we have an answer to that?
I don't have any progress being made. We know it's a challenge, but if somebody else on the call wants to talk to it, they're welcome to.
Okay, and I see a hand up, Jane.
I know I already asked this in the chat, but one of the, about the case management services. So we are a BHA that can provide problem gambling services, but we follow the SIRI guide. And so in SIRI, it does not provide a case management code for us to use. And that's why I was asking about case management. I mean, if we submit, traditionally we use T1016, if we submit that, will we be reimbursed for our services? Because when I talk to one of the MCOs, they go, well, it's not in SIRI, so you can't do this. So
Roxanne, do you want me to help with that question? Okay.
Yeah,
so case management. Case management is a great question. So thank you. Case management is a specific benefit in our state plan it's actually in a section called targeted case management. And at this point, it is very specific for SUD and specific for the allowable provider types are SUDPs and SUDPTs, right? And so that's why in theory, you see it as its own page, right? Case management under the SUD section, because it is a very specific benefit or modality within our Medicaid state plan. And when we did our state plan amendment last year, we focused on a different section of the state plan, which is 13D rehab, which impacts all the BHAs. But that's the section of the state plan that we put problem gambling in, okay? And so the sticky wicket here is that essentially, in order for us to change case management, we would have to change a completely different part of the state plan. And so that may or may not occur. I mean, we're always looking at ways to modify the state plan and improve it. But that's why in SIRI under problem gambling, we do not see case management listed, because according to our contract with CMS, it is not covered for that. So that being said, if a BHA doing SUD services and case management services, they can fold in problem gambling to that for case management, but a standalone right now for case management and problem gambling is not a covered benefit. I probably rambled.
Okay, because our providers who are certified problem gambling counselors are SUDP and SUDPT providers. So if they were to, so we couldn't, if the client only came in to see us for problem gambling, you're saying we can't bill case management. They would also have to get some sort of SUD services in order to do case management.
That's my read on the current Syrian state plan.
So likelihood, no changes in the near future for this, because we do a lot of case management services for our problem gambling clients currently. And so with this new change, we're at a loss of what to do.
Yeah, and Roxanne, I know you would, there's lots of, this is new in Medicaid, so we just launched it. And so I think we're always looking at, well, what else do we need to do, right? So I'm happy, I know Roxanne is taking this back. So we're happy to take it back to look at it further and can research that further. And like I said, we're always thinking of possible ways to do state plan amendments where we can. And the other thing is we have to have the budget authority to do it too. So sometimes that can be a barrier.
All right, thank you very much.
Melissa, I think there's a question in here about, there's a question about adolescent or teen SUD residential.
Oh, yeah.
Treatment.
Yeah.
The funding,
yeah.
The funding is still in the MCO contracts to pay for treatment. So nothing has changed in that regard. And the BHASO has some funds for low-income, non-Medicaid individuals. The two facilities I think that are referenced in terms of the daybreak facilities in Southwest and Spokane, there is proviso language in the House budget that talks about those two sites. You might want to take a look at, and we won't know if specific funding is tied to the providers for those sites until the conference budget. But there is reference in the House budget that we saw last week.
Great, thank you, Michael. Any other questions? We have 3 minutes left. Anything? Oh, I see a new message. Oh, thank you, Roxanne, for circling back with Jane. That's great. Okay, anything else? Questions, comments?
Melissa, I know we're getting down on time. What I wanted to share is just the gratitude for everyone being on. Workforce and workforce retention are really important to us. And having all you on is a sign that we have some workforce retention, so that's good. But I'm also interested, we hear a lot about the challenges, and we still want to hear where there are challenges, but also if things are working, if you have found new strategies in recruitment, or you've seen maybe a little bit of a stemming of the tide of losing staff and having staff start to come back in, really important information for us to hear. So anything that you have to share around workforce, we'd be very much open ears on.
Yeah, that's great. Thanks, Michael. Okay, anything in the works for combining substance use disorder and mental health services into behavioral health with one way of billing for those services, since substance use disorder is currently billed very differently than mental health? Great question. I don't have an answer. Do you have an answer, Michael, or know who might have an answer?
I would go back to Teresa, but and relay back to our Medicaid state plan, because I think that's in part what this is. Teresa, do you have a response around the combining of the service billing?
Can you repeat the question or tell me what it is in the chat? I'm sorry.
Yeah, it says, is there anything in the works for combining SUD and mental health services into behavioral health for one way of billing for those services, since SUD is currently billed very differently than mental health? I was just referring back to our plan and see if you had a thought on that.
Yeah.
On the billing part.
Yeah, no, that's a great question. So, I don't know if folks remember, but with the amendment of 13D rehab, again, that's the main section that is used by our BHAs that we leverage for Medicaid. It historically was very, very fragmented, and it went back to like 2003, I kid you not. So last year we did a major overhaul, and part of what you saw was instead of having SUD and mental health as two separate sections, we have one section, and everything. It's moving towards more co-occurring. There's more work to be done though. So I think that's part of where we're at, is we need to look at what does phase 2 state plan amendment look like? What does phase 3 state plan amendment look like? And how do we move more towards co-occurring in a way that works? The other thing that's on the horizon is updates to ASAM criteria. There's a lot of co-occurring stuff in the new ASAM. So there's just more work to be done. So I think, like I said, that major overhaul was a big lift. It had not been updated since like 2003. So I think we did a nice job with getting that taken care of, and we didn't lose anything because CMS could have not approved some things, but they were gracious. So more to come. And I think it's like I said, we've got more work to do. No question.
Yeah. Thank you so much. We are right at 2:30. So I want to thank you all for taking the time to be here and just your engagement in this. And I can go through too if there's any questions that we missed and try and reach out to the appropriate person for that. Michael, do you have any closing remarks before we end?
Just thank you, Melissa, and all that helped organize it. Everybody put the materials together, and for those that showed up today. So just a lot of gratitude for you guys being here today. Thank you so much.
Yep. Thank you, everyone. Have a great day. Bye.